Hafa good morning to everybody. Thank you very much, Dr. Lazama, Dueñas, Peter John, Benita, and Zenia. Thank you very much for being here, Senator Lee and Speaker Cruz. The Committee on Health put this work session together. I want to just say that this is not an oversight hearing. This is not a public hearing. This is a work session with the Committee on Health. And so I thank you for accepting the invitation. We're here today to be a player, to help the hospital in addressing the challenges that are being faced. And I know that there are issues. There are two issues, at least in my mind here. There are the funding issue that I have publicly stated that are indisputable for the hospital. There's also the standard of care issue, which highlighted by the Joint Commission report that was just issued not too long ago. And so how we got here and how the report has developed is not what I want to dwell on how we got there. We want to be able to help you. I know, Peter John, this morning you had indicated that addressing this head-on is not something the hospital may want to do at this point, addressing the Joint Commission deficiencies head-on. Correct me if I'm wrong, that's how I understood it. Yeah. And so what's very important here is that CMS certification also is an issue that I know will be in the forefront as well. And so what we'd like to do is work with you, come up with a corrective action to help you in addressing those deficiencies and also being ahead of any CMS survey that may be forthcoming. And so, we're here to help in this issue, and I want to be able to afford you the opportunity as well to speak to us on that matter.
Thank you, Senator Rodriguez, Speaker Cruz, Speaker Bisco-Lee, and Vice Speaker Terlahi. Thank you for the opportunity. I'd like to start by saying the hospital is actually very committed to working on the corrective actions, the plans of corrections in response to the findings that were provided to us by the Joint Commission. We've actually started that work already, and part of the challenge that we have is that a lot of the corrective actions that need to be done require reviews of our policies and procedures that are there. So I think if I may offer an alternative to this body, and if you're interested in working with us on the different plans, because even as we speak right now and before this meeting, there have been efforts already ongoing for different groups that are responsible there are 39 findings that we need to provide the responses to. And so different responsible parties have already started working, to address that. But part of that requires first that we do a deep dive, a drill down into the root cause of that. And so, if you would be, we welcome your participation, but we would ask that we conduct it at the hospital. We can let you know what the meetings are so that at your convenience you can join whichever one, one group that you may feel that it would be of your interest. But doing it down here, we would have to bring, perhaps policies and procedures and more individuals that could fit down here. And so we would like to offer you that alternative. We want to be open and transparent with you folks.
Yeah, and Peter John, thank you very much for that. And the purpose here is not to bring down your whole team here. The purpose here is to help us understand what you're going through and provide these immediate help from our side here in whatever we could do. So I appreciate that that is ongoing now. Okay. But for any specific help, that's where we're here to. That's where the public, through us as the representatives, are here to be able to provide that.
If I may, Senator, I'd like to offer this is an email that I received from Mark Pelletier, who is the Chief Operating Officer of the Joint Commission. And I had asked him, about the impact of funding shortfalls on an accredited organization's ability to sustain their accredited status. And he said, Peter John, good morning. As I reviewed your findings, many will need capital monies. If you have not had access to cash, this does cause organizations to fall short of meeting our standards. There have been many cases where funding has been an issue for our customers, and they too are often in the difficult position of not meeting CMS and Joint Commission standards. He goes on to say about the Joint Commission not releasing the report, but his first two sentences, speak volumes for us in terms of the sustainability of our efforts for accreditation. So I wanted to share that with you folks. I think we need to move forward, and we need to do that drill down in order to be able to do the corrective action plans. Some drafts have been submitted and were actually turned back because the important drill down had not been done. What are the underlying causes? What are the reasons below the waterline that caused a certain thing to not happen the way it should happen? So that for us is the most important thing, or part of the most important things that we need to do for accreditation, for the responses rather.
Senator, may I go?
Yes.
I just want to bring you, a history of the hospital and where we're at today and how we started this journey. When we came on board, there was a citation from CMS that really identified patient care issues. Okay, the patient care issues at the time were basically delays in service because patients had to be bumped off schedule for endoscopy as an elective procedure for their G-tubes. Chuck, you may understand that. So patients were, being, because the way we run our OR and the availability of OR suites, emergencies, big procedures are on the schedule, and they may take time, unanticipated extra time that delays patient care for nutrition, which was identified as a major issue at that time. So part of some of our initiatives in addressing, again, whether you call it modernization or expansion of service, it goes back to what CMS citation meant to GMH, and Joint Commission and CMS have different emphasis on how they do surveys. They're not necessarily all about, the citations of the Joint Commission. They really address patient care issues at that time. And so, we have been trying to figure out, I have been trying to figure out how to address the delays in procedures, and certainly, having anesthesiologists that were available in a timely manner, trying to get hospitalists on staff that could be dedicated to doing procedures have been hired. But the challenges continue to exist as we basically put patients on schedule for necessary procedures to advance them to the next level of care. So in the citations regarding, medical staff issues, medical staff related issues, this has been a ongoing problem that we've been trying to address, and I don't have a solution on my own. I have a plan on my from my standpoint as how to address this from a clinical standpoint. I'll give you an example. There was an issue regarding we don't have trauma surgeons, so our surgeons were telling us they don't handle trauma. What did we do? We hired we tried to get a trauma patient because there were some adverse outcomes, and again, I can't say the details of these cases, but there were some adverse outcomes related to unavailability of service, just like the adverse outcome of a brain injury led to hiring a neurosurgeon. So when there was an issue regarding trauma management of patients in the hospital, surgical patient hospital. We've been working on that. Now, and we actually hired one. Unfortunately, you have to appreciate the issues between community physicians and hospital physicians in the, business competitive nature of practice. So, this guy couldn't stay here being on call 365 days a year because, so we've looked at how best to address some of the challenges of patient care. Now, there was also an issue regarding hand surgical patients that were not cared for in a timely manner that led to, again, an adverse outcome, and including a resignation of staff in the hospital because they were, so to say, Senator and Mr. Speaker, that we've really not been addressing this. It's been a challenge for us trying to address it. We have to balance out the participation of the community physician involvement and the interest of the hospital, but at the same time recruiting for people to that basically can will work for what we want to do, is very difficult. So some of the citations regarding behaviors, I've reached to Medicare when I was at the hospital then. That issue that was cited there, I've reached to Medicare as to how to handle a physician who has a patient-physician relationship, was not necessarily basically complying with some of the standards of the hospital. And the employer, who's a major employer for this specific specialty group, have put him on notice that he needs, he's not. I've been told that there's some issues, Medicare, so, but in how to act on these behaviors, it's been a challenge, but we're not, necessarily not addressing it. It's, we're trying to figure out what's best to handle some of the challenges of again, you have a hybrid system where some community docs may not necessarily, and we've had experience with it. When Macmillan was the chairman, he hired a surgeon. He was run out of town of the island because he would have to work 365 days a year. Nobody would work with him to basically have time off. So it's a challenge in supporting the hospital from staffing needs that are in the best interest of the people of Guam and the best interest of the hospital. And we don't have much to work with regards to that pool of physicians.
Actually, I was hoping that this meeting this morning was going to, again, not so much work with the report or those kinds of things. I was just trying to figure out, you guys kept asking for 125 million, you wanted money, you wanted this huge building fund. But I looked through the plans, how much in there in your building plans had for expanding the number of operating rooms?
What we wanted to do, sorry, sir. What we wanted to do in our modernization, right now the medical telemetry unit is on the 3rd floor. That is a step down unit from ICU, or a step up from maybe any other unit. Anyway, so if you're a patient in telemetry or in ICU, let's say, and you're downgraded, your medical status is downgraded to telemetry, we have to put you in a hospital bed. We have to take whatever, if you have IVs with you, whatever goes with you to telemetry, goes with you. You go from the ICU through the little hallway there. There's I believe, a patient waiting area or a family waiting area that you'll pass. You'll pass into that elevator lobby where people are sitting and watching. And so before you get in, and we have to wait for the elevator. So for you to get from ICU to telemetry or vice versa, you have to go through a lot of, you're open to public scrutiny. And so one of the things that we wanted to do was relocate the telemetry unit right across the ICU so that for ease of operations, if you are upgraded or downgraded, you're just across the hallway. In order for us to do that, right across the ICU is our OR, and especially the recovery, the post-anesthesia care unit. And so we would need to relocate. We have to do something to be able to move a telemetry unit from upstairs to down there. So in this modernization, one of the things that we talked about is relocating the operating room. So we would have to retrofit that area, but then we would also have to find a place within the second floor, because that OR needs to be near the ER, it needs to be near the ICU, it needs to be near L&D. I mean, it's in that area. So that's part of what we were wanting to. We need to relocate that if we're going to do.
And was that fairly clear in the building plan? I don't recall it. I don't recall it being that.
Yes.
And your talk about the fact that they had to be delays in getting people in and out of OR. I mean, how many new
It would still be the same.
operating rooms were you planning on putting up?
Four. Still four.
We have
Still
four.
four.
But I thought he was talking about the fact that there were delays in trying to address the needs in. That was your opening statement.
Right. There was the delays, but the delays because of the flow challenges, and we're going to create again, only 3 rooms are operational right now.
And so, how much would it cost to get the fourth?
I don't know the answer to that.
Fourth up. See, those are the kinds of things that I want to know of how much we can put in now for something that's functioning to address that issue. Or that the dietitian that came and spoke about the fact that everything was in styrofoam boxes and contrary to CMS standards.
Yes.
How much would it cost to buy the dishwashing machines that she felt were necessary so we could do that, so that we could move, as you put it, meeting the nutrition needs by spending money to. Those are the kinds of things that I want to fund immediately. That if you're going to talk to me, or at least, otherwise I'll go to Mass. Tell me, how much are those kinds of things that are going to be imperative? And it sounds to me that if you're going to be going for CMS pretty soon, that dishwashing and having real utensils that go through. How much would that cost to purchase, and where would that be put so that we could move that so that you stop the styrofoam boxes and save Lazoan at the same time meeting your needs? And it would seem to me, and I went through the plan, I don't see anything about nutrition or the need to upgrade that.
Again, part of the plan discussed expanding the interventional radiology. And again, the reason for that, again, is because there's delay in putting what they call PICC lines and permacast, which are IV access, that patients need for, so those are the procedures that unfortunately end up being delayed because of those are on immediate need type of requests because of a patient and now if the current suite is being utilized and you have 2 radiologists that can do this, we cannot do it at this point until the current procedure is done.
I understand, but all I kept hearing, no offense, was Z-Wing. I was ready to.
Senator.
Z-wing and parking lot, I kept hearing in the Center of Excellence. I just kept saying, where are these plans for additional operating rooms? What are you going to do with a 14-bed ICU? Could some of those be switched over to MedTel? It's a different level, but but the thing is that they're not being used. Can you wall it off and use part of that so that you can?
For me, Senator, from where I'm sitting, I'm sorry, Mr. Speaker, and maybe Xenia can please jump in, but I think if we had that dedicated funding source that we've talked about for these many months now, the opportunity that we would be able to do to pursue perhaps even, right now we have the shortage, and the shortage, is island-wide, but if we have that dedicated funding source, perhaps we can avail ourselves of going to and using travel nurses.
And so that's what I'm trying to get to, is can you guys present us with a priority one? In order to meet CMS, I have to do this. I have to do this, and I have to do this. And if somebody mentions Z-wing, I'm going to get a brick and hit them with it. Start first with what you have to do immediately to meet the needs. How many additional operating rooms do you need? What do you need to do in nutrition to meet and not be dinged for styrofoam boxes?
Speaker, those items on the one for the cafeteria, those are included in the capital requirements for the cafeteria, but of course we had requested for 36 million, and we only got 9.5, so we had to scale it back and cut back on what we could afford. And you're also asked about what is the cost for the OR suite relocation to the Z-wing. I know you don't want to hear about the Z-wing. It's $6 million. And I don't think Peter John or Dr. Lizama mentioned, but one of the things that we're looking once we relocate the telemetry down to the second floor is the relocation of the SNU back to the hospital because of a CMS requirement that it has to be within 250 yards of the campus. And right now we're not meeting that. So that is an issue that we'll need to address at some point in the future. So this is an overall comprehensive plan that we looked at. So, the leaking roof, that's $6 million.
So is the leaking roof first?
They are all priorities.
I hate to remind you that if you use the word priority, and they're all priorities, then there's no such thing as a priority. Please, 1, 2, 3, 4, for my simple mind.
Yes, we can do that,
I
Speaker.
understand
Yes.
that all of them are important.
They are very important.
What needs to be done this year? What can be put off to next year? What can be put off 18 months?
Okay.
But because you're not going to be able to build 125 million in one afternoon. You can't even do 12 million in 3 years. So what can we do now and fund now so that we can address what is going to be the next ding? And if you fail that one.
Yes. If I might offer, Mr. Speaker, we've talked about the leaky roof. When it rains, it pours. So that's an important one that could be.
Sorry, PJ. Can I just ask, when was the last CMS survey?
They've been coming here to do specific surveys, but as far as overall general survey, they have not.
Okay. So on the specific surveys that were had, have those been addressed, and does it require buying a new equipment or fixing a ceiling tile based on those? Because that's in addition to what the speaker's asking in the level of priority. For me, what's important is what are going to be those threats to CMS certification. That's what I want to see. Number one, number two, number three, is that when they come, and they're going to come now because of this accreditation,
Correct.
of this denial of accreditation. That's where I think we need to be able to address what you need. If it's that dishwasher, that the nutritionist, which is really my first time I heard her speak that during the hearing about how that is a threat to CMS certification. If that's number one, how much does it cost? And we'll figure out a way. I think what you're hearing here is a desire, a true desire to help, right? And we know what I keep saying it, we know what the issues are about the unfunded mandate. We know. It's not going to happen. We're not going to pass a 2% increase in GRT today. But we'll do everything we could to find what is needed to address those priorities. And so that's what we're asking, is based on that, based on CMS certification of what you know is coming down, what can we do today? And then also that plus our, with some of the stuff that were listed on Joint Commission, whether those are also related to CMS certification, like the surveillance camera, the soiled tiles. Are there emergency procurement tools that we can use now to get that done today? If not, we're going to work and find a way to get you the resources.
We can look at identifying what the faster track projects that can be done, because as you said, Mr. Speaker, all of them are important. They're all important. And for things that we need to do for the patients that we take care of, each one of them, and if we had the ability to do everything right all at the same time, we could. But in reality, some of the smaller things, like the roof repair, like the electrical panel, because every day we worry that if that thing crashes, that's going to affect a lot of patients in the hospital. So those things, smaller projects, but they're still important, are critical. The IT system, I think you heard, ad nauseum, complaints about that. I mean, one integrated system that is user-friendly to everybody across that would help the nurses, would help the doctors, would help the billings. I mean, all of that that's critical. We need that, and since I've been back, I've seen them struggle with, having to make that thing work. And when it goes down, and it goes down pretty regularly, it's like, again. So that's
so PJ,
something.
who makes the call? Who's going to make the call? Is it the compliance officer? Is it Dr. Lizama, Dr. Duenas on the priority, on what's number one right now, so that when CMS does come, we can say we're addressing it. That's what we're addressing.
What CMS and Joint Commission will also take a look at, sir, is that if you know that these issues exist, what are those interim life safety measures that you could put into place to be able to, so that you can kind of mitigate it until such time that you can. Because I believe Joint Commission and CMS also, recognize that unless you're like one of the really rich, hospitals, not everybody can do everything all at once.
So who's going to make that call? Who's going to make
leadership in consultation or in advisement to the board will make that decision, sir.
Okay, and how soon can we get that?
So this is just the $125 million project?
No. This is on the life safety issues that now that you expect CMS to come down on. What are those things that we can, because some of these stuff are repeat stuff, right? And just like you said, you may have put an interim action in place in the meantime, but knowing that we got to find a permanent way to resolve that, when can we get a list of the priority that the speaker has and what I'm asking on to ensure that when CMS does come, because I think with accreditation, what's important is the CMS certification, the CMS survey is what do you need now? What do you need to replace? What can we do? Because we can't, go there and do what your team is doing, you say now, right? You have different teams addressing. We'll let the professionals do that. But what can we do here to fund what is needed in priority, in level of priority?
If it's okay with the legislature, we'll go back and we'll look at that and we'll try to identify that for you, and we can try to get that information.
How long do you think?
We'll try to get it back to you within a couple of days.
This week? Okay. Maybe by Friday? Is that? But is that fine? Maybe by Friday? Did we come back by Friday?
If there's going to be any delays, sir, we'll let you know.
Okay.
We'll let you know.
Okay. So
Although, if I may, we looked at putting up an angio suite, a separate angio suite in the hospital footprint. We just don't have any place to put it. You know, we talked about getting rid of the previous file room and radiology reading rooms. You know, and again, we've gone through this exercise, and unfortunately for us, we just don't think it, with our facilities people, we just don't think it can be place where, because Dr. Alex was ready to help donate some money to get an angio suite.
Yeah, no, and Doc, I agree with you on that, and I've always said that we need that, right? But what I'm asking specifically are the citations that you receive from Joint Commission and what you expect CMS will come down on. What can we do now to address that? Because that's an issue that's very important as well. But I don't see how that is going to come up as a deficiency, correct me if I'm wrong, right now, and threaten CMS certification by not having that right now. I mean, and so that's what, and I hope you understand where I'm coming from. What can we do right now to get in front of any deficiency that CMS would come?
And I understand that they look at the hospital, sir, but if I have a patient that since August has been trying to get an angiogram at GMHA and up to, he just got it last month. So, and this is somebody that comes in very sick. So that delay, from my standpoint as a physician, as a community, I don't know that that's and I tried to send them to GMC. They could not get access to getting on the list because I said the delay is unacceptable. I mean, cardiology care at this point, Dr. Naba takes 2 months to see. GRMC has some challenges in setting up unless you are a patient there. And so what Dr. Alex has is it put these people on. I mean, again, they were seen in October. Somebody's getting them this month because that's the only available, those 3 cardiologists that can provide some of the care. So I understand what you're saying about Joint Commission and CMS, but from a patient care standpoint and their access to care today, that could mean a life or death situation because fortunately people are not having a heart attack while they're waiting. That's what.
How serious is your collaboration with GRMC? Because they have an angio suite there, right? But how active or how, what's the collaboration you have with them?
If by collaboration you mean weakening our hospital by transferring services, cardiology services, brain services, radiology services to the new hospital to strengthen their posture, there's been no collaboration on that concept. If collaboration means emasculating our hospital, where we're weak in providing services to treat the number 1, 2, and 3 killers in Guam, there's been no collaboration on that. Now, if the collaboration means that we want, what other service can we give GRMC, share with them is, perhaps we can take a look at the maternity child services. Can that be all transferred over to GRMC? Now, that's a concept that perhaps we can collaborate on that. That's a dialogue that can start. Now, there has been collaboration sharing equipment, supplies, and personnel between GMH and GRMC. We have a physician who, if they need support there because they're physicians off island, we allow our hired physician to. So there is collaboration on that part in sharing supplies, medications, and physician expertise.
Okay, I want to go back to the point here, and Doc, and that's not to say that's not important and what you brought up on the cardiac services, but going back to my my inquiry on what my desire is and what I think we should focus on is getting you the assistance you need now to deal with the citations that CMS may come down on. And so and you said by Friday, Peter John, that you would have something then that's something we'll come back with and
We'll try.
address at that point.
But I would just also like to qualify that, that if CMS comes in or Joint Commission when they came, if they identified any condition that was an immediate threat to life, they will call, they will stop the survey, they'll walk out immediately. Not even a, can you explain this? Because it's their review of the standards, their interpretation of the standards that matters the most. So nothing that we could say would influence that. And they're very serious about that. I know Joint Commission is extremely serious about that. And I'm sure that CMS, even when they're there, I mean, they're very businesslike. If you don't have that report, it didn't exist. Even though you know that the contents of the report have been discussed, or you've had discussions on policies perhaps under the Pharmacy and Therapeutics Department, but if they don't have the actual documentation, then it didn't happen. And despite all the cajoling that we could try to do, but no, we sent out the policies. And that's what they will ding us on. So it's their review and their interpretation of what would constitute, and I think that's what Dr. Lizama and Dr. Dueñas have been referring to, an immediate threat to life. All bets are off, and nothing we could say or do would make them stop. And so it's, that's some of the things. Yes, some of those immediate fixes for like the dishwashers and something like that, we can identify that. But it's the overall patient care. If any part of it isn't working correctly, that's where they're going to hit you. So I understand where you're coming from,
Peter
Senator.
John, how long has it been since the angio suite was functioning properly? How long has it been since the angio suite was functioning properly? If I remember correctly, it's been over 10 years.
Yeah, it's functioning, but the expansion of radiology service requires more utilization by the radiology interventionists. We're offering more interventional procedure now, so it takes up the room for most of the day. Before, it was split between radiology and cardiology, but as we have expanded interventional radiology with all the advancement in healthcare, they now basically are utilizing it to, most of the day. It's the same suite that we've had when the cardiologist from Modesto came. It's just that we have interventional radiology services now that we didn't have before. We are now basically doing embolization of bleeding vessels that are really life-saving, and we didn't have that before.
Yes, I just wanted to also stress, similar to what Senator Rodriguez, I'm glad he pointed that out, that if we can get the reports as soon as possible as to what you have been cited for up to now, with that might be also continue to be put the hospital at risk of accreditation. Those should be on one list, right? And don't you have somebody on staff that's what their job is to apprise all of you as to accreditation matters and whether they're to address those things? Yeah. Can they also come to our meetings if we're going to be having these meetings?
We provided the accreditation report.
No, that's just one report, right? But he's talking about CMS, and they've been coming, doing different surveys, and I'm not sure if those are all addressed or if they're not, but I guess I just want to be sure that if we're going to make a priority list based on those, what they've cited in the past, or the potential going forward, that those are the documents we should have. And it's true. It's very hard for us to determine the priorities. We're looking to you to determine the priorities. It's not clear. We've got people testifying things completely different than what's in the packet. that you're proposing for your, money increase, except to have more money and do whatever. But it's not in your list of priorities either. I think to expand the ICU nursing services was not at all anything that we talked about. But the lack of nursing that might be creating a, critical shortage, death-threatening things. I'm just saying they're inconsistent. What's in the news sometimes, some of the doctors say, this is the problem, the lack of an MRI is what's causing deaths at the hospital, versus, lack of nursing we hear from doctors, versus this report. There's a whole different list. I looked at the capital improvement list that was submitted with the budget, and I see that the roof was there. It was a priority at that time to fix the roof. And so I think that those things can be done. So I just want it to be very clear, whatever you're going to submit, that you can use your CIP that you've already submitted with your budget request. And even the governor didn't allow all of that, right? And so he must have, I don't know, prioritized. But anyways, the CIP requests should jive with, hopefully, I want to see the CMS, is it correct? The CMS, what they're also citing. So those, I'm hoping when you create your priority list, it's going to come from one of those two, one of your past priorities and one of your accreditation priorities, or they're going to merge. That they should look the same, and the fact that they don't look the same to us is very confusing. And then we have people coming in and testifying with a completely different list of things that I don't know. It seems like that should have been, if those were truly priorities for the nursing staff, should have been brought to the hospital. That should be in the plans.
If I can just address about the two different things that people are talking about, they're actually one and the same. For me,
well, if
and
you
only
take
because
the fact,
it's funding.
if you let them
now.
say the solution to everything is we need more money, then yes, then we can join them all together. But if you take the fact that what we're asking for is not an MRI machine, we're asking for, like she said, to move the third floor down to the second floor, those things are not the same. And they're not the same as asking for additional nurses to staff the ICU, additional beds that we have already in place. So
there's a dedicated funding source, ma'am, that
yes.
The hospital needs, and there's also the other part that we want to be able to enhance and expand.
I understand your
that
plan
we have.
very, very well, that you want a dedicated funding source to do everything else, and that your plan is to do the capital improvement, certain capital improvement projects. And because we're at this point now, we've got this, I guess, accreditation threats and other accreditation threats. I think the senators are interested in dealing with those and seeing how those overlap with what you have previously requested in your budget for their capital improvement projects, if they overlap at all. I particularly want to see if there's any overlap in that, or if there's not. It doesn't look like that to me. These are things that do not look like, most of them do not look like capital improvement problems.
Senators and Speaker, if I may, the hospital has been on crisis management mode for a long time. And we're failing to look at the root cause here. It's funding. Since the hospital has been accredited, it is easier to obtain accreditation, but it's harder to sustain it. And our operating costs have been well over $100 million a year. And it's well documented in many reports that it's underfunding. And if you're talking about the reports are not jiving, it all boils down to funding, not staffing the ICU. It boils down to funding, because we don't have enough funds to be able to recruit more expensive travel nurses, or offer a higher salary to nurses so we can retain them. Just last Thursday, the ICU doctor came to my office and he said, we need to hire travel nurses because we're going to lose two of our ICU nurses are being recruited to the mainland and they're leaving. So does that mean, so we're going to go down to 4 beds, or we're going to bring in travel nurses? It's all about funding. It's all about the operating shortfall of GMH for years. And we have not been funded. I mean, when you're asking about, you know, you didn't put it in your CIP, we're not even being provided the operational subsidy to be able to meet our operations. So we have to scale back. And when you scale back, guess what? What's going to suffer? It's patient care. So the overall picture, we're negating the bigger picture here of funding. I know I sound like a broken record, and you don't want to hear it from me again, but, you know, I have to say, there have been many reports, even the OIG report. I mean...
No offense.
Yes.
How much would it cost to keep those 2 nurses?
It's not how much is to keep those 2 nurses. You have to look at the 400 nurses. You're going to try to make those 2 nurses happy at the expense of the 400 other nurses that are there. We have to look at the clinical ladder of the hospital. The clinical ladder of the nurses, that means funding. Everything is all about money. We have been on crisis management mode for decades. So and that's why we've been here, we've been appealing to you. We want you to hear.
The amount of money that you're spending in your fiscal office is making me crazy. We've discussed this offline, and I don't need to do this online.
Okay,
but you know that
Speaker,
you have been picking up people in that office that are not necessary.
We have made significant improvements in the fiscal office. You have seen the improvement in the billing. We have seen the improvement in the collection despite the decline in census. So I respectfully disagree with that comment. You need to build the infrastructure also of fiscal, because that's the backside of the hospital, as what Doris Brooks have said. I respectfully disagree with you, but, we need to look at the overall picture of the hospital. It's all about funding. It's all about the shortfall. So I don't know what else I don't know if, you guys are not looking at that picture, and maybe I'm missing something. Please tell me if I'm wrong. That, if you are in an operational shortfall for decades, how long do you think that business is going to sustain? How long do you think it will remain in operation? The nurses and the doctors, they do the best they can. The clinicians are here. They're explaining the challenges they've had with the one angio suite that is being shared by interventional radiology, who, their job is to make, to prevent invasive surgery. And then you have the heart doctor that, they have very limited hours of when they can come in to use it. And I see the challenges, I see the frustrations in all those doctors, because they come to my office too. They come in and ask for supplies. They come in and ask if we can buy them this equipment. And guess what? We're out there pounding on businesses to donate to the hospital. That's not how we run a hospital, always asking for handouts, always asking for donations, or maybe get a used equipment. Just last week, we had half a day. They brought in their anesthesia machine because ours broke down. Otherwise, we have to close the OR suite. These are the challenges that GMH faces every single day. And it is very frustrating. It is very challenging to run a hospital like that when you cannot plan.
Can I chime in, or is it private, or can I chime in?
No, Doc, you can go ahead.
Yeah. I thought we'd come here to talk about these accreditation issue. But the overall funding is a challenge too, and Benita's right. We need funding, but if I take a step back, I wasn't here for the first half an hour of the meeting. But first of all, I disagree with GMH when you guys held the press conference to talk about Joint Commission. Okay, I really was upset that you guys stood in front of the Z wing. If I can speak my mind, a lot of the doctors felt the same way, because the Z wing to me is an administrative wing. It is not a wing that we do clinical care in. So for GMH to do that, I totally disagree with that, 2 days prior to the hearing. But be as it may, that when you go out to the public and do a press release in front of the public, and you bring out the JCO, you're going to expect the senator to just come back and ask for the report. I know that the report should remain confidential, but when we go out in public and do a press release, don't expect any report to be confidential in that case. But I did read a report finally, and I did ask for it. I asked for the report myself as a medical staff. I think I deserve and have the right to read a report, and I wasn't given the opportunity. And I think majority of our doctors didn't have the opportunity to read a report. So if the report was critical, it was effective patient care, then the doctor should be the very first to know what was going on, and we weren't offered the opportunity. So be as it may, let bygones be bygone, and we focus moving forward. Now, majority of doctors agree that Joint Commission is a luxury. If we can't afford to have Joint Commission, it's okay, we focus on CMS. And I assume that what you guys are talking about now is to focus the accreditation issue on CMS. And CMS is actually a federally accreditation agency, and I think they go a step beyond Joint Commission. Joint Commission will give you all this you have to do to go training, etc. That's fine and dandy, but I think CMS comes in to look at the doctors and how they function. If you did something wrong, they'll actually fine you. And to me, that's even more important. But more importantly, when you come to funding, I think the luxury of paying Joint Commissioners come down every time they want to feel like coming down and we don't have the money. I'd rather see that money be spent on medications and repairing tile, roof, or whatever it may be. But I'd rather see that be done. But as far as CMS goes, they pay us. We don't pay them. So I'd rather you stick with CMS accreditation. So that's the accreditation aspect of it. Now, I heard somebody brought up I don't know if it was Speaker Cruz or Senator Rodriguez that brought up the collaboration between the new hospital, GRMC, and GMH. The new hospital was built to supplement GMH. That's what I understand. I testified against the tax break. And I suggested the tax break, don't give it to GRMC, use that funding, the tax collected from the new hospital, and have that as a dedicated funding for GMH. But nobody listened. The tax break was given anyway. So now we're in a situation where the question is asked, what is a collaboration? And I don't know if I heard Dr. Duenas correctly, but he has suggested that perhaps GRMC can absorb the maternity, or I don't know when, with all due respect.
I wasn't sure. Senator Rodriguez asked me, what's collaboration? I said, we never had collaboration to emasculate GMH, Tom, if you were here. But if that means collaboration, what other medical service can we give to GRMC to move them forward? And I said, well, why not the maternity? That may be a service that we want to put up there. I'm not sure. I don't know what collaboration meant.
Okay, let me talk about that a little bit.
Yeah.
And when we talk about collaboration, you look at what's the strength of each hospital. What are the strength of GMH? What is the strength of GRMC? I'm not in the administration. I don't get paid by GMH. I don't get paid by GRMC. So I'm independent. When I look at both hospitals, be as it may, the tax break is already done. It's given to them. It's okay. Be bygones, be bygones. But how do we survive with two hospitals? Competing with each other is not going to work. And I think GRMC agrees with that. But as far as duplicating services, and when you look at it, and if you talk to the management side, GMH is not the one to be duplicating services in their defense. Our service exists for the purpose of taking care of patients that non-pays, and that's an unfunded mandate that we have to be able to fund. And Benita is right, we do need funding. But when you look at collaboration basis, okay, look at what the strength is over at GRMC. What do they do better than GMH that we can afford to send over, or what we can afford not to have at GMH, okay? As far as maternity goes, and I'm an OB, I've been delivering baby at GMH for 22 years. I can tell you that it's the heart of the hospital. You can ask Peter, John, and Benita what the finances are for the OB side, okay? I could jump ship, I could go GRMC, but you'll be losing tons of revenue. That's not what you want to do. Furthermore, baby can come in less than 10 minutes. 90% of your OB-GYNs live within the facility 5 minutes from GMH. You can make the delivery from Tamuning to GRMC in 10 minutes. There's no way. Okay, so you're going to have doctors missing deliveries there. GMH delivers 2,000 babies a year, just last statistic that I've seen. Okay, so the strength of GMH is the obstetric side. And I'm not being biased. I'm there every day, and I see that. If you end up Benita, ask the nurses at Xenia, they will tell you the strength of GMH is that. Now, when you look at the strength of GRMC, what are they good at? Dr. Lizama says, hey, they have a cardiac suite. They have the cardiac cardiology department. Those are their strengths. So let's work together and see what we cannot afford to give up and to keep. Now, as far as the leaking tile goes, I don't know where the leaking tile goes, but if you look at the architecture design of GMH, it's a hole in the middle. It's like a square, but it's a hole in the middle. The entire architecture design, if you look at all the leaking areas, is all the rain pouring and straight down to the middle where the courtyard is on both sides. That's where, when we looked at the maternity design, we discussed the leaking roof situation. When the architect evaluated the areas, that's where all the water is coming through. Typhoons, it's not coming from the side of the wall from GMH, it's coming straight down. And during the maternity renovation, this is what we're supposed to take care of, the leaking roofs. When you talk about repairing the leaking roof, that is the main area. You don't have to have an architect to tell you where the water is coming from. It's pouring in from the center of the hospital. When the maternity, the new nursery that goes in covers up the entire center court of both sides of the hospital, and that completely seals off your leaking roof situation from the top down. So that's a priority if you want to fix the roof, is to get that nursery out there and get that repaired. And I'm just speaking on, you know, what I'm telling you from the architect, okay? And we've gone through that. We spent a whole year and a half doing the architecture design, and we talk about those leaky roof situations. If you look at all the tiles that you put in, where is it coming from? It's from the center court, all from the center court. So if you want to fix the tiles, you fix the maternity side, okay? And that's your revenue side. It's not that much. And I agree with Speaker Cruz. You know, you want 125 million for capital improvements. You can't even get a $9 million improvement done. How are you going to expect them to win the confidence of GMH to do the other stuff done? So we got to make sure that we get our priorities straight and do that. And as far as collaboration going back, I think, you know, it's time to sit down with maybe Mike Cruz, who's the director there, and ask them, what can they give up? What can they keep? What can GMH keep? What we can afford to let go? So those kind of stuff that we have to work together, collaboration. As much as I don't like it, that the tax break is given to an entity that's private and for-profit entity. I thought those taxes has helped GMH. But they created a hospital saying they're not going to compete with GMH, but the fact is they are competing with GMH. They are. That's why the census are down. The services are being duplicated. Okay? I'm not finished yet, but if Larry, you want to chime in?
Well, you know, I disagree with your statement that basically we can collaborate with on the cardiologist. Senator, I have to staff the hospital with internists, okay? In staffing internists, they need services from specialists, okay? You're not going to find the internists of Dr. Duenas or Dr. Taitano nowadays. People are coming here basically trained to send specialty problems to specialists. So if we're going to have internal medicine problems at GMH, we must have support, or we'll never basically staff them with people unless we get them from doctors that have served Indian health centers or third world countries because they think that we are. In my 8 hospitals, they express their frustration. They don't want to continue this type of practice where they don't have available specialty service on site. Now, cardiologists, so I have to get a cardiologist to provide a service for an internal medicine. Now, do I get a cardiologist that does consult only? Do I get a cardiologist that does only, you know, again, you know, it's very difficult in your thinking about how to collaborate and you know, have GRMC be the cardiology center and we're the non-cardiology place, because there are other cardiology problems that require a cardiologist, and you can't get a cardiologist that's just going to see somebody for heart failure. You're going to get a cardiologist that's going to come in who's going to take care of heart failure and be able to do other things. If you're going to get the right people to come here to Guam that is going to be basically bringing top-notch care for Guam. So, you know, as we both exist to take care of the adult patient population, we need to support the adult patient services. And that's ICU, pulmonary, interventional radiology, and so forth. Now, again, you know, Dr. Duenas talked about collaboration discussions. We haven't had that discussion because, you know, we really don't know how to make this work. I mean, they have tapped into I'll give you an example. They have tapped into the STEMI program. That's the heart attack program that is identified out in the community through the EMS system. Okay, so they go to GRMC. That cardiologist can take care of a patient with a heart attack, but he can't do the pacemaker. So when a pacemaker is needed from GMH, where do they go? Again, even in the cardiology field, they become more specialized. This interventional cardiologist at GMC has its limitations. But again, in order for me to get a cardiologist at GMH and get the right cardiologist that will support today's internal medicine hospitalists, I do have to give them somebody that they can have faith in the practice and standard of care.
Larry's my internist, so I can't argue with Larry. You know, he may not want to see me again, but but I understand where he's coming from. Okay, I think all the doctors are frustrated. We all want what's best for our patients, but I think like I said, going back and trying to get a tax break back for the hospital is difficult. But Larry's right in a way that we have to be able to provide the minimum care that's needed for cardiology patients, for OB patients. For example, GMH does not have a maternal fetal medicine, which is the standard of care across the country, that we should have a maternal fetal medicine. I bring them in. We have the only maternal fetal medicine on the island is Dr. Gray Hirata. And he comes in and he helps us pick up fetal heart defect, congenital defects, things like that. Severe, highly diabetic patients, we take care of them. But I pay for his services coming in privately. I have him see our patients, okay, and consults. But if the angio suite is what we need, then we should work at that. But I think right now, when we talk about collaboration, I can understand where Larry's frustration is coming from is, you know, when you talk about new hospital, they may not want to give up this, they may not want to give up that, but there's got to be a minimum care that internal medicine has got to provide so that we can provide the patient with that basic, at least essential services of care. But, you know, going back to Benita's issue about funding, I think we do need funding. Putting the Joint Commission aside, okay? I'm not going to get upset anymore about the press conference. I'm not going to deal with this Joint Commission. As a doctor, I'm board certified. This government in Guam doesn't even require doctors to be board certified, okay? If board certification was that important, why not require it? Every doctor on Guam be board certified. We don't require that, okay? And it doesn't mean a non-board certified doctor is not good. It's just that perhaps you got to pay for board certification, and the doctor may say, hey, I don't want to pay that money to go get board certified, or I don't have the time to do it. That's their choice. It's okay. But we got to keep our CMS certification because that's federal funding. So I think if we can focus, switch gears a little bit, if we can have the luxury of going through Joint Commission, then let it go. It's okay. We're going to function the way we're going to function. We're going to take care of patients, we're going to function. But CMS certification is something we have to focus on. We can't lose that. And I think Peter John understands that. I talked to Benita as well. So I think whatever footprint that we need, we still got to fix. But to expect, I read the Joint Commission report, okay? They want 100% of our doctors, every single one. If we have 200 doctors, we have 200 of them to do that computer for 4 hours, sitting there to do it for 4 hours. That ain't going to happen. If we're going to lose accreditation because one doctor that doesn't do it and 99 doctors did it, then so be it. And Joint Commission has appeared to be like a big bully, and they come anytime they want, and they expect them to pay them to come. And we don't have the money to pay them to come. They come anyway, regardless. And that's, to me, that's unfair. But the funding issue, there's got to be accountability, Benita. If we want funding, we've got to be accountable for that. Maternity service, hey, listen, we've gone through a year and a half of painstaking meetings, and I took my time off every week to get the A&E done. And it's 3 years, he still hasn't done it. And I share the frustration with Speaker Cruz. He wants to give you guys the money, but we can't prove it to him that we can't get things done. And I understand, it's just USDA funding issue, etc.
Doc, please, yeah.
Okay, I'm sharing my frustration. If you can let me just talk. And I took my time off to come here in the middle of my patients. So those are the frustrations that we share, and I understand the funding from USDA. And I talked to Jay Ross from GITA, and GITA is one of the main problems. GITA is one of the main problems that give away all these tax breaks, and now the government situation the way it is. Okay, and I testified in front of GITA and said, don't give this GMC a tax break. They went ahead and did it anyway. They went ahead and did it anyway. You can read my testimony at GITA. Okay, and the situation now, we're still short on funding. We talked to GITA. We want to convert the GRT to sales tax. GITA comes back. Oh, we can't because the bond is associated with it. But if you be creative with it, you can, okay? The bond, I talked to Jim Atkins, I talked to a lot of business persons, they took the bond, they had the lawyers read it, re-identify the term, business privilege tax. If you re-identify that term, you go to a sales tax, you don't have to worry about internet sales. Internet sale can be taxed now as a sales tax. Right now, you can't apply that because you can't do it. But redefine that term, business privilege tax, to a sales tax. Convert it over. Everybody pays the same. Okay? Then everybody don't have to worry about the GRT. You're going to collect more, I bet. But I think the issue is here, if you want funding, we've got to make sure we justify that funding. And I read the capital improvement project, and I think we do. If we can move toward a comprehensive center, providing every single service that we can, ortho, angiogram, and as we get older, we got to have cardiology care. Those things we can do. But we got to make sure that we be held accountable for it. If we just ask for $100 million without a concrete A&E plan, like you guys made us do for maternity ward, a year and a half, we've been doing that. And I'm frustrated because we did that. Painstaking labor, we took our time out, we did it, and we're still not there. So let's get that done to make sure we can do it. And once that's proven, yeah, next step, one step at a time. But getting $125 million, I disagree. You got to make sure that, hey, you show one project at a time. Start one project, finish it up. Start another, finish it up. This is how we run a business. I don't run a business, but I'm going to do everything at once. You finish it up. If you can complete it, prove it to them, we can do it, and then we move on.
Doc, I mean, you've raised so many points that I want to bring out. First of all, you know, you're blaming the hospital for you know, you had mentioned that they can't even get a $9.5 million project done, and then you're asking for more. The hospital, you know, and I had this discussion with you, that you look at the funding source. This is USDA. They are very rigorous in their, and very, very detailed and very tedious in their requirements, and it is very time consuming, and it has been very difficult because they, first of all, they waived the requirement of interim financing, and then later on they reneged on that, they went back. I mean, you know, if the funding source of this project had been another source, we probably would have been cutting the ribbon right now.
I agree, and I told Peter John last year.
So it is not the hospital's fault. The hospital has done many projects, and they have done it successfully. They have renovated the ER, they have done the ICU, and you know, and there are other projects, the elevator projects, but
I understand, but I told Peter John last year, and Peter John, if you recall, and I still have the email, a year and a half ago, I said, hey, listen, if this project through USDA is going to be an issue, why not include it into your annual budget? Include into your annual budget, submit it to the legislature, and I hear Speaker Cruz say it all the time, tell us what you need, put it in the budget. But every year we forget to do that, and we leave the mothers and babies behind. And it was just 3 years down the road. It's going to be 4 years pretty soon, by the way. So why not include in the annual budget?
Doc, you know, we submit our budget, we don't even get our operational funding, subsidized. And have you noticed that the entire conversation here, when you think about it, step back and look at it, what does it boil down to? Lack of funding, right? It's all about It's all about funding. Even the L&D, it's all about funding.
I know. Okay, let's put that.
So it's
let's
like
put the L&D to rest.
No,
we're just
I'm going to stop. I'm going to, Doc, if we could, we want to move on here, and so we want to get back into why we're here this morning, right? And that's important, and that's moving.
Yes,
on.
and that you're talking about the accreditation side, right? Yes. Okay, so let me finish up with the accreditation side. We'll get back. The funding issue, Peter John, if USDA doesn't come through, include it into the budget. I said it publicly, include it into the budget. And then you have justification why you should include it into the budget, because that's your revenue source. That's your revenue source, okay? Now, accreditation, I read the report, okay? And as a doctor, when I go through every detail of the report, some of the points they brought up does do with funding, okay? Some physical stuff. But I don't think the physical stuff is going to lose your accreditation. There's some other points that we brought up. Processes, the leadership of the medical staff, what Dr. Duenas said, we have to hold ourselves accountable. Yes, we do. We got to go to some of the meetings. But I swear, some of those meetings that we did attend, that they say, hey, we didn't conduct in 2016, I have no idea where that came from, because I was sitting in that meeting myself. In 2017, I was in that meeting, and they say we didn't have a meeting. That doesn't make sense to me. So either the minutes wasn't created to show them that we had that meeting, or something went wrong there. There's some bookkeeping issues, okay? But if Joint Commission the guy who came down is not being forefront with us. If he has a chip on his shoulder, maybe it was the wrong person who came down and did the survey, then we don't need somebody like that. Because if they can't be honest with him and they don't take what we did, we had those meetings. But the accreditation issue is not all funding. We have to take ownership of it, like Dr. Duenas says. Some of them is about funding. If we need to upgrade a computer system, we have to do that.
That's funding. The computer system.
That's what I'm saying.
It
That's what I'm
has
saying.
gone down. It's always down, and that's a frustration, and that does impact patient care. And by the way, that's $20 million in our 125 modernization that we don't need.
Okay, if you're
an
going
LME,
to
whatever.
you know how much it
design.
costs to network my office? $25 million to network the hospital. You better go get a better deal with that.
GRMC spent $30 million, and they were having a lot of problems with it.
I understand that, but you gotta take it one step at a time, okay? But to ask for $30 million just for networking, somebody is taking you for a ride. But I think the issue here is that if we want funding, we have to show them that, hey, we've got to be accountable for those funding issues, and I'm sure they're working on it. But let's give them a list what we need, But not every single issue on the accreditation list that I read.
Yeah,
Okay.
Doc,
Thank you very much,
have
Doc,
the plan.
for your input today. Benita, we're going to move on here. Peter John, you have anything else that you have?
I just wanted to, because Dr. Shea wasn't here when I started, but I got an email from Mark Pelletier from Joint Commission, the Chief Operating Officer, and he said, as I reviewed your findings, many will need capital monies. If you have not had access to cash, this does cause organizations to fall short of meeting our standards. There have been many cases where funding has been an issue for our customers, and they too are often in the difficult position of not meeting CMS and Joint Commission standards. So funding is at the bottom of it. Yes, there are processes and other things that you've mentioned, Doc, but a lot of it goes back down to funding, whether it's not funding the operational needs or even the ability to do some of the other things like hire hospitalists or develop the clinical ladder so we can recruit and retain nurses and other professionals. So it's funding. There's funding there.
Okay.
I
And so
understand.
PJ,
We need. What I'm saying is we need funding. Okay, I've run a business as well. We need funding, but we can't just say we want a blanket statement of funding, and you threw out a capital improvement, and those are new services. Let's upgrade our current services. If Dr. Lezama needs angel suite, then focus on that. Get that completed, and then move on. But if you ask for a blanket statement that we need funding for all this all at once, and the bill that I read didn't even isolate the funding. It goes to a general fund. If you want funding, then you create a bill, an honest bill, and then put that money in a lockbox that says this is an account for GMH to access. No governor can access it. Only GMH can access that money. Period.
Doc, that was Bill 141 and 142 that you're talking about.
Well,
Yeah.
Thank you very much. So Peter John, you keep referencing that email, and thank you for that. There was an opportunity for the hospital to voluntarily pull your Joint Commission accreditation. That wasn't an option that you guys thought at that time to do, right? So at that point, did you guys do what you're doing here today? You're saying you're doing that deep dive and looking at what the source, where's the root problem of these deficiencies?
What's your, I'm sorry, one more.
Was that done at that point in time when you had that option to voluntarily give up Joint Commission accreditation? From that point that you
We
guys...
hadn't gotten the report yet, sir, that was provided to you.
But you had an opportunity, right? There was back in October, I believe, that the same individual, was it the CEO, Mr. Mark Pelletier, had indicated and gave an option for the hospital to voluntarily give up their Joint Commission accreditation because of the challenges that, I guess, from a previous survey at that point.
But he was saying also that they still needed to do the follow-up survey, which was done in January.
No, so my question was, at that point, when you had those, if it's deficiencies or whatever it's called, did you do that deep dive that you're saying your people are doing that deep dive now?
The problem that's for the second survey that came back up in January. We did the first one already back from the
And those
August
were all
visit.
addressed. And those were all addressed.
Those were all addressed. And, we submitted our corrective plan of action, so they were saying, okay, so they're going to, schedule a follow-up visit.
Okay.
Senator,
So, yes.
if I may, just to answer that question, is in August of 2017, we did have a survey for cause, and we looked at all the root cause analysis, and we gave our action plans in, was accepted by Joint Commission. They came back in January, and they looked at, and of those that we corrected, 7 were repeats, or 5 or 7 were repeats. Although we gave them the action plan, but when they came back as follow, well, did you guys implement what you said? They found that 5 or 7 were repeats. But they also did surveys that had nothing to, they didn't come just to, they also did other things to do, and they found more challenges. And those new challenges, we are now by the 20th of this month, we will have completed our root cause analysis. We would have identified the behavior, the process, and whatever breakdown there was, and that's going to be submitted by March 6th. But yes, action plans were done. Many were fine, but they found 7. I keep saying 7. I don't know what's 5, and they were repeats, and those were repeats, and many of those repeats were from the medical staff.
And so, just to close up on that, because the first time we heard about the modernization plan being tied to accreditation was in early January, when the news release came out that accreditation may be in jeopardy because we haven't addressed the modernization. And so, I wanted to tie that all in and see if, how we could have addressed it at that point when it wasn't being pulled yet at that time. Right, and so that's why I asked that question. But going back to what I asked earlier, I know I asked for a Friday meeting. I'm going to ask, are you able to do it on Thursday instead? Because we're not able to use this place. But if you're able to do it on Thursday, to get your people to come back and give us that list, because you hear the speaker's commitment as well, and the others, that we'll find a way to address what is needed immediately.
We'll work on it, sir, and I'll do my best, but I also have my set of responsibilities, my plans of corrections that I also need to do. Mm-hmm. So we'll work on it, and we'll see what we can come up with.
Okay,
for you.
so we're here we're in the same team. We want to help you.
Yes,
and so
I
if you
understand,
need more time, I'm not going to hold you to it. I'm just saying that we're here to help you. If you can come up by Thursday to let us know what you need, we'll address it.
And if I can just maybe end, at least the dedicated funding source is critical, sir. I think we've done our due diligence with regards to submitting to the legislature those budget requests. The modernization includes things that will tie into, so it's hard to separate
I hear you,
them.
PJ. We have to separate at this point because we're here at this point today. Is that you have this accreditation. I'm not saying that, as we heard Dr. Shea, he says, hey, and I don't know if that's the hospital's position too, that we probably need to just put that aside, Joint Commission, but what's important is the CMS certification. And so that's what we're asking you. Tell us what you need to not get us into this situation with CMS, and that's what we want to address now. And we're not going to forget about what you need, the dedicated funding, the modernization. That's happening. The speaker's in recess for the Governor's Bill 230. Our offices are collaborating and looking for ways to make that happen. That's going to be addressed. But what needs to be addressed today is to ensure that we don't have any that we avert any deficiencies that may be coming with a CMS survey.
And so the time spent on these plans of corrections is going to be critical to that effort to also make sure that we mitigate anything from CMS.
Okay, but some of the things that we heard from the dietitian is that the dishwasher or the equipment that's used for the utensils is not operational. She said at that time that it was in violation of CMS, I guess, guidelines, things like that. Give that to us. The other stuff, your professionals, I'm not going to dive into that. That's your work.
Yeah.
Yes, Senator.
Thank you, Mr. Chair. I just wanted to reiterate a request that, or a question, I guess, that the Vice Speaker had raised. Is there somebody on your staff who is identified as a QA or does quality assurance that has an outline of all of the things that JCO has deemed as things that we need to take a look at, as well as things that are going to potentially come up in this upcoming CMS certification process? And she was basically saying that the list of the JCO recommendations or the JCO challenges that they've identified, and maybe perhaps the CMS certification challenges that we're having trouble meeting, some of them should overlap. And so that kind of gives us the information that we need. And I understand, Ms. Manglotnia, that you feel like a broken record, that you're constantly coming to us and saying it's funding, it's funding, it's funding. And just know that we're here to work with you, but we're also going to be coming back to you and saying we need information, information, information. Because we cannot just give handouts. We need the information. And I think that what the chair and what speaker have asked for, maybe like a table for us, very simple table, a list of priority concerns, a certain cost to those, and a timeline. So like, okay, in this next month, these are our red items that we need to address immediately so that we don't lose CMS certification. And then, in the next quarter or the next 3 months, these are the other things that we need to tackle. Just, so that we can, as Dr. Shea said, continue to move forward. We're here, we're at the table, we want to listen, we want to help you, but you need to empower us as well with the information, with the data, with some of the numbers. Come to us and let us know exactly what we're dealing with.
We have come many times.
Yes, I know, and I've been here. We've been listening.
The operational shortfall, that is testament enough. And now you want to dwell into the previous reports, and you need professionals, you need doctors and nurses to help you interpret that, because if you don't, if you look at it yourself,
so that's why we're asking you to come up with a chart for us, because we are.
So now we're gonna stop this process and come up with a chart for you, so that you can understand the report. So that's what the chair
and what the speaker has already asked you for. I'm just reiterating that request.
It just boils down to funding. The hospital has not been provided adequate resources. How many years? The operating losses, how many years? We have asked in the budget, but we have not been provided. I've been there. I can speak for my submission, because it's been 3 years, and I've never been given the resources that is needed.
Right, and from our position, we're not being given the resources either. We need to be able to have resources in front of us to say, these are the, I'm sorry.
Because we have,
you can continue to talk over me, but at the end of the day, we need the information from you. All these people that came to testify, nurses and doctors, they were privy to so many of these reports. We had no clue about what was going on.
If you were really interested, you could have come to the hospital and come to those numbers of hearings or committee meetings.
We don't have to go down this path. We don't have to go down this path. Okay, if I've asked for information, well, we don't have to go down this road. We're here to be on the same team, Benita. I know your frustration. Everyone's frustrated.
I am very frustrated.
And so we are asking for that information, and I'm asking to have it by Thursday or before Thursday, and we'll come back here.
So, Senator, if I get correctly, you're talking about going through the list. Which listing is associated with funding and what can be fixed, and which list is not associated with funding from that Joint Commission list, correct?
That's what I've asked.
Okay. Well, that's also CMS. You're going to fix that. You're going to try to fix CMS and see which is associated with funding, which is not. I can do that. Yeah. I'll do it tomorrow.
Oh, well, you have a doctor that's there to help you.
If I can have a comment,
Okay, yes, and we'll end with you, Doc.
CMS their blueprint for the next, when they come, they're going to be following our current, my guess is, and it's probably a close to fact, is they will use the public disclosure of our survey, and they will use that as a blueprint of where to look and see. So by March 6th, we must get this completed, Now, JACO may be uses to go to JACO if already, as Tom says, he doesn't want a JACO, but CMS will pick up the ball. They'll follow that roadmap that JACO has already presented to us for improvement. So we're still very serious about correcting what we just had.
And thank you, Doc, because if that's the issue, then tell us from that report. Tell us what is needed to address it now. What could we do? Because all we can do now is give you the tools to be able to correct those things. So on Thursday, if we can get that report, okay? Thank you very much. Thank you.